Hi, Chapter 6 is entitled The Central Venous Pressure. If you walk up close to the ICU monitor, you'll see these undulating waves of the CVP, and you'll often see a number next to the CVP, which is, a computer-based average assessment, usually from the highest point to the lowest point. So it's kind of a garbage number, even though I see it used as the definitive CVP in ICU patients all the time. Let's focus in on this cardiac cycle here and talk about the waveforms. So the first of the three positive deflections, okay, there's tends to be three positive deflections of the CVP and two negative deflections. The first is the A wave, and this is determined by, these are temporally in sequence here, atrial contraction. And electrical conduction precedes, usually by milliseconds, the pressure conduction within the cardiac cycle. So this is the increase in pressure in the right atrium as a result of the right atrial contraction. And the height of this pressure wave is dependent upon the strength of contraction, the volume transferred, the compliance of the atrium at the time, which is volume dependent. So at very high atrial volumes, actually, compliance is low, so for a given volume, pressures will be higher, and that can become important in patients who are overloaded. Often you'll see these waveforms most pronounced in patients who are wildly fluid overloaded, and if you picture their atria just massively distended, poorly compliant because of the massive distension, then that poor compliance is going to make the pressure changes even more pronounced, so you'll often see all these waveforms in overloaded patients. So because it follows the atrial contraction, the A wave is absent in AFib. It's, flying along at a rate of 300 in atrial flutter. And if it's contracting against a closed tricuspid valve, i.e. you are in a state of atrioventricular dissociation, you'll see very high A waves, and we call these Cannon8 waves, and you'll typically see that in conjunction with a low cardiac output beat. So if you have an A line in the patient, you'll see the Cannon8 wave, and that will correspond with that beat with a low systolic pressure because the output is lower as you've lost your atrial filling. So this fills the ventricle at very end diastole. It kind of packs the right ventricle to the brim just prior to the onset of systole. And then at this point here, the tricuspid valve closes and you get isovolumic contraction in the right ventricle, and that's discussed in Chapter 2. And then this blip, the second positive deflection of the CVP, which you may not see because it can be below the limit of detection on many CVP monitors, is the C wave, and this is essentially just the billowing or the bowing of the tricuspid valve backwards into the right atrium during systole, and this occurs even when your tricuspid valve is totally competent, and it's just, you can sort of picture the valve tensing backwards like a parachute opening during systole. So the important thing is that the A wave marks the end of diastole, and so the C wave marks the beginning of systole. So end diastole is actually this little valley here, and we call that the Z point, or for my friends in the True North Strong and Free, we would call this the Z point, and this is end diastole. So this is actually here your end diastolic filling pressure. This is really the true filling pressure of the heart that you want to know, again, at end expiration. So if you wanted to measure a true CVP, you would wait for this undulation to signify end expiration, and then at that point at end expiration you'd look for the Z point, or conversely you could freeze the monitor and correlate that with the onset of the QRS, because that's the onset of systole, and that would represent your true CVP, your true vascular distending pressure prior to the onset of systole. Following the C wave, as systole progresses, you can imagine the right ventricle during systole, the papillary muscles are contracting and actually pulling the tricuspid annulus downwards, and the pulling of the tricuspid annulus downwards actually increases the capacitance of the right atrium and lowers the pressure And the lowering of the pressure is the X descent. You can sort of picture that like a piston pulling down. The pressure above the piston would then drop, and that's going to represent your X descent in the right atrium. But filling continues throughout systole of the right atrium, and so then pressure begins to rise again until you get to the very point of the third positive deflection. This is the first negative deflection. The third positive deflection is the V wave, and at the very pinnacle of the V wave, this is when pressure in the right atrium supersedes right ventricular pressure, and when the pressure in the atrium is above that of ventricular pressure, and this occurs at end systole after the stroke volume has been ejected, then the tricuspid valve opens, and then you have the Y descent, and that's the drop in pressure as the tricuspid valve opens. So the V wave, you can imagine, you'd expect it to be very tall and abrupt if you had an incompetent or leaky tricuspid valve. We call these tall V waves. Moving on to the Y descent, a large Y descent represents a large pressure gradient between the right atrium and the right ventricle during the onset of diastole, and you can get that. You can see that in restrictive filling defects, because if the right atrium, if it's like a constricted pericarditis and the right atrium is very constricted, that its pressure will go very high, and it will fill at a very high pressure at end systole. And then as the tricuspid valve opens, that high pressure in the right atrium compared to the low pressure in the right ventricle will lead to a very pronounced Y descent. That's in contrast to true or classical textbook cardiac tamponade, and this is what we call coupled pericardial restraint, and it's coupled because all of the chambers of the heart are being exposed to the same high pressure fluid that is the pericardial fluid, and that's when all the pressures within the chambers begin to equalize during diastole. And in true kind of classic textbook coupled pericardial tamponade, you lose the Y descent as the pressures equalize between the two chambers at end systole. And this reasoning falls apart when you can actually have a kind of pericardial tamponade known as uncoupled pericardial restraint, and that's if you have a loculated clot or a loculated fluid pocket around, say, in and around the right atrium. So actually it can mimic restrictive filling, where you can have a very high right atrial pressure and a low end systolic ventricular pressure, so you maintain your Y descent during a loculated kind of pericardial tamponade. So the presence of a Y descent does not rule out tamponade. The presence of a Y descent does rule out the textbook tamponade, where the entire heart is surrounded by a high pressure fluid. All right, I talked too much about the CVP tracings already, so what do I want to talk about now? So the deflection, the true CVP, the true end diastolic pressure we talked about, it corresponds with the onset of the QRS. So this portion here is systole. So remember, systole ends at the apex or the pinnacle of the V wave, and it begins at the Z point. And so during systole, this is where you would see tricuspid regurgs in the tall V wave. Blue line here is pressure. Going up is increase in pressure, going down is a fall in pressure. And this sea level, this light green line here, dotted line, is a very important pressure, and this will be the intra-abdominal pressure. This is the right atrial pressure, the heart anterior, this is the diaphragm posterior, this is the inferior vena cava. So this is if somebody's sort of lying on their back and you're assessing their IVC using an ultrasound. So this waterbed looking thing represents the venous capacitance beds, and most of your blood volume lies in the veins, and so the volume of venous blood pressing out against the walls of the veins generates this elastic recoil pressure, which is very important, called the mean systemic filling pressure, and I've recently written about this on Pulm CCM.
And this generates a pressure pushing blood into the heart. And then up here, this is the arterial bed. So 70% of your blood roughly is in the veins, another 20% roughly in the arteries, and then maybe another 10% or so in the capillaries. And this is a low compliance, so the walls are much stiffer than the veins, and it's a low volume arterial tree. I believe the compliance of the arteries is about 30 times less or 30 times stiffer than the veins, which is why when you eject blood into the stiff arteries, you get your mean arterial pressure, which then pushes blood back to the venous system. Round and round we go. So this venous bed is pushing blood through the IVC towards the heart. And this blue dot here is very important. This blue dot throughout the animation will represent the right atrial pressure or the central venous pressure. And it has a few conflicting forces driving it up or down. So the right atrial pressure will tend to rise relative to the intra-abdominal pressure, again the green line here, and that would tend to dilate the IVC. It tends to rise when there is an increase in venous return from the venous capacitance beds and or cardiac function is impaired. So the heart cannot eject blood as well from the thorax, so that tends to pool blood in the central veins and raise that right atrial pressure. So it could be it could be from one or the other or a combination of the two that raises the right atrial pressure relative to the abdominal pressure. Conversely, the right atrial pressure can fall relative to the intra-abdominal pressure, and this would tend to shrink the IVC volume. And that can occur similarly as a consequence of two general concepts: a fall in venous return from the venous capacitance bed, so blood is kind of trickling in, or if cardiac function is excellent and the heart is pumping out all of the blood it's receiving. So it could be one, both, or a combination of the two. So let's talk about what happens during a spontaneous inspiration. So when you breathe in, right, intrathoracic pressure falls, and the heart will bring that right atrial pressure below the abdominal pressure here, the green line again. And when that occurs, the transmural pressure of the IVC becomes negative and it collapses. And what I've illustrated here is this tends to augment venous return, this increase in the blue arrow here, which is why you tend to bolus the heart when you breathe in. Similarly, this is also why breathing in spontaneously or decreasing the pressure within the thorax tends to increase left ventricular afterload. So it actually increases the pressure gradient from the heart to the arteries, but it improves influx of blood from the thorax, kind of like blood rolling downhill versus blood being pushed uphill. So that's a spontaneous inspiration. So let's go back to baseline. We're back to our right atrial pressure baseline. Now, what happens with a purely mechanical inspiration? So this is the patient that you've just intubated and is paralyzed, or the patient is heavily sedated and making zero inspiratory efforts. So in this situation, the pressure in the thorax rises relative to intra-abdominal pressure. You can see here, and that's going to cause IVC dilation. So in patients who are completely passive with the ventilator, and so in some of the IVC papers, particularly I believe the one by Barbier in 2004 and Faisal as well, they were looking at IVC dilation. And that was in a patient population that was essentially paralyzed, not making inspiratory efforts, and they were also receiving relatively high volumes on the ventilator, I believe 8, 10, 12 cc's per kilogram. And so that dose of volume is also going to affect how high the right atrial pressure, how high the intrathoracic pressure rises in response to a mechanical ventilation. And that would change if the volume dialed into the ventilator was less or more. So that tends to retard venous blood flow. So now the blood flow kind of has to roll up this gradient, so it's diminished. But at the same time, this is why a positive pressure breath kind of helps unload the left heart. It lowers the gradient from the left heart to the arterial tree. So let's go back to our baseline. Now, what happens during an assisted inspiration? So this is incredibly common in the ICU, but it also applies to patients who are on high flow oxygen CPAP, BiPAP, they're receiving positive pressure, but they are also alert enough to trigger a breath. So as the breath is triggered, there'll be initially a negative deflection followed by a positive deflection. So the right atrial pressure may fall below intra-abdominal pressure and then rise above intra-abdominal pressure. So you may see IVC collapse, but it's hard to standardize this because patients will have varying effort, varying lung and chest wall compliances, varying degrees of PEEP applied. So that will complicate things. So let's go back to our baseline. And now let's talk a little bit about specificity and sensitivity. So let's call an impaired specificity of IVC collapse when the IVC collapses in a patient who will not respond to fluids. So what might bring about that situation? Well, consider a patient with septic cardiomyopathy, so their heart's not pumping forward as well, but they also have the venoplegia of sepsis, and maybe they're on some PEEP, either they're intubated or on CPAP or BiPAP or whatever, because they've got a pneumonia, say. So what this animation does here, you can see the heart getting big and the right atrial pressure rising. What that is to illustrate is this cardiomyopathy. So it doesn't necessarily mean that the heart is big and dilated and has systolic dysfunction. The heart can be impaired by a plethora of physiologic factors, but it's just simply to illustrate the point that the heart is not ejecting blood from the thorax as well, so that tends to raise the right atrial pressure. And as you can see, that would tend to distend the IVC because it's increasing relative to our sea-level intra-abdominal pressure here. But say also this patient's sepsis is evolving and they're becoming venoplegic, also vasoplegic, but also venoplegic. And what that does is it tends to kind of increase the capacitance of the venous beds. So their volume, blood volume may stay the same, but because the venous beds are kind of becoming big and floppy, that elastic recoil pressure or the mean systemic filling pressure falls. And that tends to lower inflow and therefore lower the right atrial pressure. So you've got this heart, this kind of crummy heart that's not pumping blood out so well, but at the same time you've got this venoplegic physiology where where blood is not coming into the right atrium as well. So the right atrial pressure may not change so much. Now here's the kicker. As I said, the patient is also on PEEP for whatever reason. And what is often forgotten and is nicely illustrated in a number of trials, it was initially postulated decades ago and then kind of shown in a classic paper by Henry Fessler in the early 90s in Saul Permit's lab at Hopkins, and then again by Jelinek and colleagues in 2000 in humans, and was also shown kind of nicely in a paper by Yule Olson in healthy volunteers, that when you apply PEEP to the thorax, you also pressurize the upper abdomen. And so what that does, what the PEEP does, is it raises your intra-abdominal pressure. So see the green line is rising. And so what that is going to do is you can see if you're raising the pressure around the IVC, it's going to make it more likely that it will collapse, even though this patient is not going to respond to a fluid challenge. What you have here now is a situation where the IVC appears small and diminutive as a consequence of low venous return and a high intra-abdominal pressure. So now when this patient breathes in, it will just continue to collapse. And then if that patient takes a really negative inspiratory pressure, it will collapse all the more. But as I said, this patient will not respond to fluids. So this will impair your specificity. It will give you a false positive. You'll see the IVC collapse. You'll say, oh, hey, this patient will respond to fluids. I'm going to give them a challenge, but they actually won't. So clinical states where you need to look out for where you will see IVC collapse in a fluid non-responsive heart, as I've illustrated, low venous return. And that could be from a lot of reasons. If somebody's hemorrhaging badly, if they've got venoplegia, if they have adrenal insufficiency, all of these things will lower the mean systemic filling pressure and lower the pressure of blood entering the IVC. Importantly, when there's increased intra-abdominal pressure and or the application of PEEP. So another good situation might be the cirrhotic, right? Cirrhotics are venoplegic, and then they may have ascites and intra-abdominal hypertension, which would tend to collapse the IVC. Obesity would also do it, any cause of intra-abdominal hypertension. And then also, as I've illustrated, excessive inspiratory efforts. If you breathe in very deeply, you can force that IVC to collapse even if your right atrial pressure is high and the heart is on the flat portion of the Starling curve. So let's go back to our baseline, right atrial pressure, and now let's consider the converse, an impaired sensitivity of the IVC. So this is when the IVC collapses minimally or does not collapse in a patient who will respond to fluid. So this is the patient, you look at the IVC, it looks relatively dilated or engorged, and you think, oh, I'm going to stop. But in actuality, that patient would respond to a subsequent fluid challenge. So it's somewhat the converse of the previous one. So consider a volume-loaded patient. You've given them 4 or 5 liters of crystalloid for probably not a great reason, but they've received it. They're breathing without assistance, and maybe they're on some epinephrine because you like that pressor. So now the mean systemic filling pressure is high because of all the volume you give them, and also because the alpha effects of epinephrine will cause the venous beds to clamp down, and now you're going to have a high pressure head pushing blood back into the thorax, which will tend to raise the right atrial pressure. And let's say that cardiac function is okay. You know, maybe the patient's got some diastolic dysfunction, maybe they flipped into AFib, maybe they kind of had a septic cardiomyopathy, but the beta effects of the epinephrine is actually keeping cardiac function relatively reasonable. So that right atrial pressure maybe falls a little because of good, decent cardiac function, but not a lot. And then say this patient doesn't take a terribly deep breath in at the same time. Well, now you're going to see the heart and the right atrial pressure fall, but it might not quite get to the intra-abdominal pressure, even though the venous return curve is still intersecting an ascending portion of the cardiac function curve. You may breathe in, and it won't quite get below that intra-abdominal pressure, and you won't see IVC collapse, or you'll see just a little bit of collapse. Another possibility, and this was shown in a paper by Kimura, I believe, where you can actually breathe differently if you breathe diaphragmatically versus if you breathe with your chest wall. If you breathe with your chest wall, you won't have as much IVC collapse because the intra-abdominal pressure is probably not changing to the same degree. So clinical states which favor minimal IVC collapse, but in a patient who's fluid responsive, could be seen in a state of high venous return, as we've seen, if there's decreased abdominal pressure, or the patient is using accessory muscles to breathe rather than diaphragmatic muscles, or in patients with less vigorous inspiratory efforts.